Good afternoon. My name is Silke Gillessen. I'm a medical oncologist from Switzerland, and I'm going to talk about the Advanced Prostate Cancer Consensus Conference, or short APCCC. These are my conflicts of interest. So you could ask, why do we need a consensus conference for advanced prostate cancer? It is because there are several topics in this setting that we deal with actually every day, where there is no evidence, or only sparse or low-level evidence, or conflicting evidence, and more so different interpretation of evidence. And then, as you know, in most trials, the evidence is generated only in a very selected patient population. It's important to say that the results of a consensus conference are not guidelines. They are really recommendations from experts. So I will talk about the last APCC that did take place in 2022. We had more than 190 consensus questions developed with all the APCC expert panel. And for logistical reasons, in reality, because of COVID, the voting took place prior to the conference in a web-based survey. Here you see the 7 topics of APCC 2022, but because I have only 10 minutes, I'm going to just tip on the locally advanced prostate cancer setting, the metastatic hormone-sensitive prostate cancer setting, and management of metastatic CRPC. Here you see our panel from 2022. So you see this is more than 100 panelists from all over the world. As you see, they are also from different disciplines. So we have urologists, radio-oncologists, clinical oncologists, and oncologists. And then we have some non-voting members that are coming from the imaging. Also, we have someone from pathology. So in that sense, we have a very mixed panel. Here you see the APCC 2022 publications. And it's important that they are all available open access, so everyone can read them and consult them if they want. So there are 2 from the conference, both published this year, one in European Urology and the other in the European Journal of Cancer. I'm just showing you some results, and I think we are all very interested in this disease. That's PN1M0 disease. So more and more patients with high-risk prostate cancer are operating, and we find more and more patients who have a PN1 disease, and we didn't see the lymph nodes in the imaging beforehand. And the big question is, should these patients get adjuvant radiation? Here were the questions. So for the majority of patients who have 1 or 2 pathologically involved pelvic lymph nodes with the surgery and extended lymph node dissection, so PN1, without evidence of systemic metastasis, and with an undetectable post-operative PSA, what would you do? Would you do monitor and do a salvage therapy in case of PSA rise? Or would you give adjuvant radiation therapy, or adjuvant radiation therapy plus systemic hormonal treatment, or systemic hormonal treatment alone? And you see here, when high-risk features are not present, and high-risk features are E-subgrade group 4 and 5, or PT3 stage, or positive margins, there's really a clear consensus, 81% of the panelists, that would just monitor alone and do salvage therapy in case of PSA rise. That looks different if a patient has 2 or more out of these 3 high-risk features. So here you see half of the patients, of the panelists, would still monitor alone and then do salvage therapy only in the case of PSA rise. And about half would give adjuvant radiotherapy plus or minus hormonal treatment. So you see no consensus here in the second group of patients. If we go to a very important topic, this is metastatic hormone-sensitive prostate cancer, we asked about the role of combination treatment. And what is very clear, there was a very clear consensus from 97% of the panelists that you should give patients combination therapy, at least to the majority of patients. There's always exceptions, but I think this is very clear. So ADT alone for the majority of patients is not any longer standard of care. For the triplet therapy in metastatic hormone-sensitive disease, that's a very hot topic, but please remember that this APCCC, so the results were from 2022, so this was before ESMO 2022, before ASCO 22, and also before all the conferences from this year. And we asked in which patients with metastatic hormone-sensitive prostate cancer who are obviously chemotherapy fit, would you recommend the triplet therapy, ADT plus docetaxel plus a novel endocrine agent? And you see here for de novo disease, only 4% would give it to the majority of patients independent of disease volume, 70% only in high volume patients, and a quarter of the panelists would usually not recommend a triplet. Again, that was in April 2022. For metaconus hormone-sensitive disease, it's a bit different. You see here, 37% would usually not recommend this combination, and about 60% would give it only in high-volume patients. A very important question in daily life is the management of frail patients. And there we ask the question, how do you identify vulnerable or frail patients? And that was the question. So in patients with metastatic hormone-sensitive disease who are more than 75 years old, do you recommend a geriatric assessment before you choose your treatment combination? And here you see a quarter said yes in the majority of patients. More than half of the panelists said yes, but only if red flag issues were raised during consultation, and 19% said no. So I guess that's something that's quite interesting, because obviously officially there's very much recommendation of geriatric assessments, but you see in real life also the panelists, we had another question, admitted that they're not doing it very frequently. Then I'm coming to another very hot topic, so that's PARP inhibition in metastatic CRPC. So the question was, is PARP inhibition only for molecularly selected patients or for all comers? And you know, we have the PROPEL trial. So again, in April 2022, only the PROPEL data were reported, not yet the TALAPRO-3 data. And here was the question, in the majority of patients with mCRPC that are about to start an AR pathway inhibitor, do you recommend a combination with a PARP inhibitor as first-line therapy? And for BRCA1/2 alterations, it was half-half. Half said yes, half said no. Again, this was before we had the updated data from PROPEL and the new data from TALAPRO-3. For the patients who had a pathogenic DNA repair gene alteration but not BRCA, only a quarter said yes. And for patients without a known DNA repair gene alterations, there was a clear consensus, 97%, to say no. So in conclusion, these consensus conferences are not high-level evidence like phase 3 studies or systematic reviews and meta-analysis. But at least in ours, in the APCCC, this is expert opinion from more than 100 experts from different disciplines. And it can be very helpful for daily clinical practice. And interestingly, there are many areas with non-consensus, and this can help us to find gaps where clinical studies should be conducted. And now I want to say that we have the next conference in April 2024, so the 25th to the 27th. Everyone is very welcome to participate in this conference, and we will ask some of these questions again. because we have updated data, and we will, of course, also do new questions that all concern advanced prostate cancer. With that, I thank you for your attention, and I'm open for questions.